Hey, future HFAs. So in Module 2, Medicare reimbursement, our goal is to look at how does Medicare know what to reimburse SNF providers? And when you are running a nursing facility, maybe you're a director of operations, how do you project that Medicare and oftentimes managed Medicare reimbursement? All right, future HFAs. So, what is PDPM? PDPM is the acronym for Patient Driven Payment Model, and we'll go into more detail in the upcoming slides. But the main thing that I want you to understand is that uh, my goal for this module is to give you some exposure to Medicare reimbursement with SNF providers, but it would be impossible to do an all-encompassing PDPM deep dive. So we're going to hit on some of the most important topics of PDPM, how that correlates to your Medicare reimbursement, and when you are running a SNF, how to project it, how to teach it, how to anticipate it. So patient-driven payment model, effective October 1, 2019. There's a couple things I want to unpack right away. The first is October 1, 2019. October 1 is a very important date for Medicare providers. From home health, hospice, SNF, hospitals, any type of healthcare provider out there, October 1 will always be earmarked in their calendar. October 1 is the beginning of the federal government's fiscal year. What that means for Medicare providers is every October 1, we see some type of change to how we get reimbursed or how much we get reimbursed. Sometime you may see in the news headlines that Medicare is going to do a 5% increase to nursing home, or typically it's the opposite, or there's gonna be a shift to value-based reimbursement as opposed to the old school payment prospective payment system. Every October 1 is when these changes take into effect. So October 1 of 2019, SNF providers saw the biggest change in how they got reimbursed from Medicare since the mid 90s, going back to cost based reimbursement. So that shift was PDPM. Like the name implies, its goal is to be patient driven, meaning what Medicare pays a nursing facility should be driven by the patient's individual needs. And that's kind of what's key is they want to improve the accuracy and the appropriateness of what SNFs get paid based upon the needs of the patients they serve and specifically the individual patient that they serve, as opposed to lumping it all together and then giving out these average rates. All right, guys. So PDPM, I think the best way to begin to understand PDPM reimbursement is to take a moment and briefly discuss the way nursing homes were reimbursed by Medicare before PDPM. It was just called RUGs, and we still have RUGs today, but we were reimbursed off of Medicare RUGs, and they were 66 distinct RUGs or resource utilization groupings, reimbursement categories basically. And not to get too much in the weeds, but basically before PDPM, what Medicare would do is they would lump all of the therapy needs together, PTOT and speech, and then they would lump everything else. So you have therapy over here, and you have everything else over here. You have nursing, uh, uh, social service needs, any special dietary needs, anything. So you have two over here, and they would lump it together and you would get a dollar rate per day. Now, if you had 10 Medicare patients in your nursing home, you may have 10 different uh, per day per diems for Medicare, meaning you may get paid a different rate for each 10 of those patients. The thing is, what you got paid was a bundled amount where they just threw together all the therapy needs, all the nursing and social service needs, put it together, did their magic, and then we got a rate per day. we were not getting paid based upon the individual needs of the patient. And that brings us to PDPM and why it was such a drastic change for Medicare SNF providers. If you look at the diagrams below, you can see that PDPM is going to reimburse SNF providers based upon those 5 categories. So look at patient A. The red circle is PT needs. That represents the physical therapy needs of the patient that we are serving. OT is occupational therapy. Nursing would be nursing needs like IV therapy, medication management, things like that. SLP is speech language pathology. NTA, non-therapy ancillary. Now, briefly, NTA basically is the restorative programming that you're providing for a patient. There's no point in getting in the weeds of what that is. Basically, it's where a non-therapist is trained, like maybe a CNA or a QMA, they're trained on a restorative program to help the patient with the activities of daily living, usually focused on the late loss ADLs, like eating or maybe even ambulating from the bed to their chair, things like that. But the point is, under PDPM, you actually get a dollar amount based upon each specific need within those 5 disciplines. So look at patient A, look at patient B. Patient A, PT needs, the red circle, is smaller than the PT needs, the red circle, for patient B. What that means is that patient B, now both these patients may be in your nursing home, but patient B, maybe they admitted after a total knee replacement or a hip replacement. They have a lot of physical therapy needs compared to patient A, who may be admitted because of pneumonia or because of COVID or something like that. Patient A does not have the physical therapy needs of patient B. Therefore, if you were to look at their reimbursement amount side by side, you will get paid more in the physical therapy component for patient B than you would for patient A. And if you go around that circle, it's the same concept. Patient A has lower nursing needs than patient B. Maybe patient B developed COVID in-house, and suddenly now they have big nursing needs as well as PT needs. So patient B, you will receive more per day for their nursing needs than you would for patient A for their nursing needs. So as you can see, instead of taking all therapy and all nursing and lumping it together and then giving a blended rate, PDPM actually provides the nursing home specific dollar amounts for each of those 5 disciplines based upon the needs of that patient. All right, so a couple things with PDPM that we also have to discuss. Not only does PDPM tie the per day reimbursement amount to the actual needs of the patient, PDPM also encompassed more value-based purchasing components than the prior way nursing homes got reimbursed. Now, a couple things I want to unpack for you here. Value-based purchasing is a term that my past students have found a little confusing, and I understand why. The term value-based purchasing sounds like if you worked in accounts payable and you're trying to find the best deal on your supplies, but you have to expand upon that and think of it in the terms of what is Medicare doing? We are providers. We're providing a service like OT, PT, speech, nursing, what have you. Medicare is paying for it on behalf of their Medicare beneficiary, on behalf of the patient. So, in essence, Medicare is purchasing physical therapy from the nursing home. That's why it's called value-based purchasing. But when you see that term, think of it really as value-based reimbursement, meaning Medicare wants to pay providers based upon the value that they are providing, not just the quantity, meaning the outcomes, the quality, things like that. So under PDPM, there was a lot more value based than prior, which is a good thing. We want to pay good providers, good nursing homes. We want to pay them more than bad ones. So under PDPM, there's a couple multipliers that we have to talk about. Now, this calculation will not be in your assignment because it's pretty in the weeds. This is a screenshot of an actual PDPM calculator. And what it does is it looks at the three components, and essentially those indexes or those multipliers impact the rate for that nursing home, what they get paid by Medicare. The first one in yellow in the screenshot is the wage index. Now, uh, the wage index is pretty simple. Basically, if you are in an urban area, say if you are in Indianapolis, compared to, say, a small town in Southwest Indiana, say Princeton or Fort Branch, what have you, what if you're an administrator, you're going to have to pay higher wages if you're in Indianapolis than you would in, say, Princeton, say Vincennes, um, probably even Evansville, because the cost of living in Indianapolis is higher. Therefore, your wages are probably going to be higher too. Medicare tries to take that into consideration. So that wage index of 0.9138 means that based upon the geographic location, and this one is in Evansville area, Warwick County, it's considered urban, so it may be Newburgh or maybe even Boonville, but they are getting a specific wage index multiplier based upon the anticipated wage expense or labor expense of what they're going to pay of 0.9138. So whatever the payment is for PT, OT, speech, nursing, NTA, whatever it is, whatever dollar amount it is, that 0.91 will be multiplied by that dollar amount. So you can see it's a little bit lower for the Evansville area. Now, maybe Indianapolis is 0.98 or even 1.02. What that means, if you're a provider in that area, you're going to take that the amount that you're getting, the dollar amount for PT, OT, speech, what have you, the PDPM rate, you're going to multiply it by a different wage index, and you can see if, let's say, the daily per diem is $100 to make the math simple. The nursing facility that you see in front of you, the Indiana, Warwick County, Evansville area wage index of 0.91 means even though the fee schedule says $100 per day for that discipline, say it's nursing, they're not going to get $100 per day. They will get $91.38 per day because they're taking that wage index times the fee schedule rate. Every value-based reimbursement multiplier works like that. So we'll move on to the next one, value-based purchasing multiplier. This one is very interesting. So from a Medicare perspective, one of the most important indicators of value or quality in nursing home is now readmission. Now, I am sure you've heard Readmission Reduction Act and the importance of decreasing unnecessary readmissions. For a nursing home, that measurement is based upon the patients that they accept from a hospital system, and then are they able to keep that patient and provide quality care, improve that patient's outcomes, or does the patient decline and end up being readmitted back to a hospital system? So the readmission based value based purchasing component is not readmission to your nursing home, it's the patients that you get, and then do you readmit them back to a hospital system? In this situation, the SNF has got a score of 98%. That would be a multiplier of 0.98. So the equation is the same. Let's say that we have the same reimbursement amount, $100 per day that you're going to get for the nursing component of the PDPM rate. But that's not what you're going to get. That is what is the stated fee schedule. But based upon your value-based purchasing multiplier, you're going to get 0.98 times that 100. You'll get $98 per day, not 100. You want to get the full 100, you have to improve your readmission rate. The last one is quality reporting program. Now, this is based upon some quality metrics that nursing homes have to report. It's actually not tied to their quality outcome. It's tied to them reporting it. So this specific nursing home got 100%, but let's say that they didn't do their quality reporting program and they only got 95%. Same equation. The fee schedule may show that they should get $100 per day for the nursing component of the PDPM score, but because they didn't do their quality reporting program, they're only going to get 95% of that, or $95. It's a very complicated equation, and that's why I only want to touch on it. It won't be in your assignment, but it's important to know that all of healthcare, from nursing home to hospital to home health, everything in between, Medicare is shifting to value-based, meaning they are not going to keep paying providers simply based upon what they've done for that patient. They're going to start correlating what we get paid based upon our outcomes. And that is good. That is what we want, because we're all taxpayers and we're all funding the Medicare program, and uh, we don't want Medicare providers who are not providing quality care to receive additional funding. That just doesn't make any sense. So value-based purchasing is a good thing for healthcare. It just complicates how we get reimbursed. Okay, so the last PDPM caveat that we're going to talk about before we dive into your assignment is called variable per diem adjustment. Now, hang with me because we've been through a lot of information. We discussed what PDPM is, we discussed its components, we discussed how it's different from the previous way nursing homes got reimbursed, we discussed how it ties in value-based multipliers, and the last one that we're going to talk about is how it ties in a variable per diem based upon longevity. How long is that patient in your nursing home? How long have you been billing Medicare for that patient? Now, the calculation is pretty much the same as it was for the value-based multipliers like readmission. As you can see from the table below, when you have a patient and you're billing Medicare and they are in your SNF from day 0, day 1, to day 20, you will receive 100% of what you're billing, assuming that it's appropriate. Now, here's a caveat. On day 21, let's shift from day 20 to day 21. What you are doing as a nursing home, what your staff is doing for that patient has not changed. The needs of that patient, if you go back to the diagram of the different circles of the PT and the OT and the speech and nursing, that's not changed. Let's assume from day 20 to day 21, nothing has changed. But you will get paid 2% less than you did on day 20. On day 20, you will get 100% of that dollar amount. On day 21, you will get 98% for no reason other than that patient is now there for another day. You will get that 98% all the way up to day 27. Day 27 turns to day 28. Let's make the same assumption that nothing changed. The patient has the same needs on day 27 as they do on day 28. Become day 28, you will receive only 96% of that dollar amount. The reason why they do this is they're very transparent about this. They don't want nursing homes to continue to bill Medicare if it's not necessary. And it does make sense when you take a step back and think about it, because the longer that someone is in an inpatient setting, whether that be a hospital, an inpatient rehab hospital, a nursing home, a rehab unit, what have you, the longer the patient's in there, the longer they're being exposed to infection and disease, and the longer that maybe they are in bed a little more than they would be, what have you. So the idea with PDPM and the variable per diem adjustment is to incentivize providers to discharge the patient appropriately. And that is based upon policymaker studies that determine that a patient doesn't need to be in a nursing home for 60 days, right? 100 days. Although Medicare will pay up to 100 days with copays, they feel like the most appropriate is 20. Or I should say, what Medicare should be paying for is closer to 20 than closer to, say, 48. So with each period that progresses, you do lose some reimbursement. Okay, so let's talk about your assignments for Module 2. You have a couple of assignments. You need to do a voice thread after reading the case study on PDPM. Read that handout and then post a voice thread. Your voice thread is pretty open-ended. It can be, you can discuss what you found interesting, maybe what you found agreeable, disagreeable, maybe something that you found confusing. And then after that post, you need to comment on one other student's post, do a voice or do a video, and discuss maybe what you found agreeable. Maybe you disagreed with that student's perspective. Maybe something that student said confused you. Do a post, and then our PDPM assignment. We're going to go over that in the upcoming slides. It is an Excel assignment, and you will be calculating PDPM rate for a nursing home. So with the PDPM assignment, you're going to calculate the base rates for your nursing home based upon those 5 disciplines we discussed: the PT, the OT, the speech, the nursing, and the NTA. What we have on the screen here is one screenshot of the speech language pathology discipline. And on the left-hand side, the left column, you have these variables: SA, SB, SC, SD, SE, SF, SG, SH. Now, those variables are the needs, specifically the speech therapy needs of that patient. It's outside the scope of this class to dive into what makes up the SA category versus the SB category. But you need to understand how it's calculated, meaning if your nursing home is getting paid for the speech component at a level SA, that's going to pay you $14.19 per day for that speech component, as opposed to maybe a speech component of SB, which would pay you $37.98 per day. What makes up that difference? It's very important to know that, and hopefully you will have an MDS coordinator or a director of utilization or a really astute CFO who can further dissect the differences, and if maybe that's a passion that you have down the road, to really dive into the clinical components that make up that difference. But for the purpose of this course, the idea is to be able to look at these tables, take the PDPM category that's given, find the dollar amount, and then calculate your overall Medicare reimbursement rate per day for each patient. Okay, so this is your assignment. You will have a spreadsheet that looks just like this in the module. And if you look at the right side of the screen, the SLP column in the light red, you will see the same columns that we saw on the previous slide. That's speech. This handout is all disciplines. So you have your PT, OT, nursing, speech, NTA, and at the bottom right, in the gray, you have a non-case mix. Don't worry about that. Basically, every SNF gets a certain amount, and that's what we get. So I'm not really going to cover it, but it is included in your base rate calculation. So on the top left in the blue, in column B, cell B4, you see physical therapy base rate. And then you go down And that PDPM category for physical therapy is TD. So now we go to the green table where we have PTOT, and we go down to the PDPM category TD. We go to the right under the PT column, and we see $107.32. That means for the PT category TD, we will get $107.32 based upon the specific PT needs of that patient in our SNF. Then we go to the right under occupational therapy. That PDPM category is also TD. So we go to the green table, find the TD row, and under OT, it's $79.61. So for the TD category, that's how much we get. And you continue that down the line until you get to the very end, and you have the PDPM base rate of $675.96. That is the sum of the dollar amount that we receive for each of the 5 components. And that makes up your PDPM rate. Now, as you can see, those are base rates. We have excluded the value-based multipliers. We've excluded the wage-based multiplier. We've excluded the variable per diem multiplier, where the longer the patient is in the SNF, the longer you're billing Medicare, the less that you get. I just want you to be able to calculate base rates because I want you to understand when you are running that nursing home, when you are the director of operations, even though you're going to hopefully have people around you that this is what they do, they're experts in clinical reimbursement. You have to understand that this is how we get paid. And if you're running the nursing home and you're responsible for a bottom line, you need to understand how we get paid for Medicare. So this is a really good assignment. I wouldn't classify it as an easy assignment, but if you have any questions at all, don't hesitate to contact me. Okay, future HFAs, that's it for Module 2. We discussed PDPM, we discussed your assignment. Just want to say, while you're doing the assignment, don't hesitate to contact me if you have any questions at all. It's not an easy assignment. Healthcare finance inherently is not an easy topic. So if you get stuck, if you have a question, if you just want something to be clarified, don't hesitate to contact me. You can always get me by email. And texting me is completely fine. Just let me know who you are, and then I will text back, and we can set up a call if needed. But if you need me, just give me a shout. All right, future healthcare leaders, that is all for this module. Please comment below. Let me know what your thoughts are. Let me know if there's a topic that maybe we need to cover that I can add to our coursework. Also, let me know if there's something that you think is maybe off base and we need to change up. Until next time, I'm Brody09s.